She must be one of those few who remember doing this.
A very good afternoon to all of you. I, Dr. Ranel, MCH resident from the Department of Endocrine Surgery, welcome you all to this happy occasion of the 34th Foundation Day celebration of the Department of Endocrine Surgery and day 1 of the 15th postgraduate course in endocrine surgery themed Thyroid Surgery Everything Under One Roof. From its inception, the Department of Endocrine Surgery at SGPGIMS, from taking baby steps to making giant strides, has evolved, and today we are celebrating the 34 glorious years of its existence. I request Professor Gaurav Agarwal, Head of the Department of Endocrine Surgery, and Dr. Sabha Ratnam, Organizing Secretary, to escort the dignitaries to the dais. We would like to take this opportunity to express our hearty welcome to our Dean, Professor Shaleen Kumar, and our Director, Professor R.K. Bhiman, to kindly grace the dais. We extend a hearty welcome to our chief guest. We extend a hearty welcome to our chief guest, Dr. Vijay Oza, President of Postgraduate Education Board, National Medical Council, who is also an accomplished urologist, to grace the dais. I request our nursing colleagues from the OTN ward to felicitate the dignitaries with a bouquet of flowers. I request all the dignitaries on the dais to light the lamp of knowledge to mark the beginning of today's program. May I request Professor Anjali Mishra and Professor Gyanchand to join us on the dais. May I now invite our Dean, Professor Shalin Kumar, to deliver his welcome address.
Good afternoon. Chief guest of today, Professor Vijay Oza, President, Postgraduate Medical Education Board, National Medical Commission, Government of India. Director, SGPGI, Professor Radha Krishnan Bhiman, sir. Professor Gaurav Agarwal, Professor and Head of Department of Endocrine Surgery. Dignitaries on the dais, off the dais. Senior faculty colleagues. Ladies and gentlemen, on the occasion of the Foundation Day of the Department of Endocrine Surgery, as Dean of this institute, I take this opportunity to extend a very warm welcome to our distinguished chief guest of today, Dr. Vijay Oza, who is the President of the Postgraduate Medical Education Board. Sir, it is an honor to have you in our midst today. I extend a warm welcome to our director also, Professor R. Radhakrishnan Bhiman, a noted hepatologist and a renowned academician. Professor Gaurav Agarwal, Professor and Head of the Department of Endocrine Surgery. Distinguished orators, Professor Ashok Shah from MSKCC, Professor Owen Ung from Brisbane, Australia. Both of them need no introduction to this august gathering. Invited guests in the audience, senior faculty, residents, and friends. I welcome you all for this 2.5-day, 3-day extravaganza, academic extravaganza. I'm very happy to share that not only has the Department of Endocrine Surgery put a well thought out academic program, but they are also conducting their alumni meet alongside. The department has ensured a significant involvement of the alumnus in the academic engagements during this period. In fact, the program in hand says it all. Over the next 3 days, they plan to brainstorm on all aspects of thyroid and parathyroid malignancies and various interventions. For the delegates and young aspiring endocrine surgeons, I welcome you all and hope you enjoy this academic treat. Once again, sir, I thank our chief guest, Dr. Vijay Oza, President of NMC, for taking time out from his very busy schedule and gracing the occasion. I'm thankful to Dr. Bhiman for coaxing each department in this institute, including the Department of Endocrine Surgery, to celebrate their Foundation Day. And this is something that our director does with great fervor and enthusiasm. And also to invite the alumni to on the occasion of Foundation Day. I thank the delegates, and I hope that all of you have a fruitful time ahead. Thank you.
Thank you so much, sir. I request the head of department, Professor Gaurav Agarwal, to present a brief report of the activities of this department in the last 1 year.
Thank you. Chief guest of today's function, Dr. Vijay Oza, President of the Postgraduate Medical Education Board of NMC, Director, Professor R.K. Bhiman, Dean, Professor Shalin Kumar, Organizing Secretary of the 15th Postgraduate Course in Endocrine Surgery, my colleague, Dr. Sabaratnam, invited faculty for the 15th PGES, both those who are present here in the hall and the two orators who are connected to us remotely from their respective places. Delegates of this conference, officers, faculty, members of various other departments of the institute, alumni of the department, faculty colleagues and residents, nursing and paramedical staff, office personnel, support staff of the Department of Endocrine Surgery, ladies and gentlemen. I welcome you all to this 34th Foundation Day of Department of Endocrine Surgery and the inaugural function of the 15th postgraduate course in endocrine surgery. This department was founded this day 34 years ago when Professor S.K. Mishra, the first faculty and the head of department, joined this nascent institute. Ours was the first academic department in the country. We started the first structured training program in endocrine surgery as hospital service senior residents were inducted since 1989. Subsequently, the department started the first postdoctoral course in endocrine surgery in 1997. And then in 2004, after due permission from the then Medical Council of India, this department started the first MCH course in endocrine surgery in the country. Initially, we had two seats per year, and then 2010, we increased it to 4 seats per year. From a single faculty department with just 4 beds and 1 operating session every week in 1989, the department has grown considerably today to be perhaps the largest and the most active endocrine surgery department in the country. I'm happy to say that we have been able to maintain our leadership position not only on the national, but also to some extent international postgraduate medical education scenario. Thanks to the untiring efforts of the past and the current faculty members and the support we have received from various other international and national institutions and the successive directors, deans of the institute, as well as faculty and leaders of our sister departments, endocrinology, radiotherapy, nuclear medicine, and some others, we are currently able to achieve what we have, what we can. I joined this department as a trainee in 1994 and subsequently as a faculty in 97. And so I find it particularly humbling and honorable task for me to be presenting this report in front of you. As the head of department, an office which I assumed in October 2022. I'll now be presenting a brief report of the activities and achievements of our department during the year gone by. And it gives me immense satisfaction to report that there's been an overall qualitative and quantitative enhancement and improvement in all spheres of working of the department during this past 1 year. Here, I wish to thank our director, Professor Dhiman, and the institute administration for kindly accepting my earnest request for creating 2 units in the department. We have had among the highest bed occupancy rates in the last few years in our wards, and hence we were granted a 2nd ward similar to the most other major departments of the institute. The alumni and those who have been following this department for some time would find it specifically significant that we now have 2 units and 2 wards, unlike what you would be remembering from your own times. We were given space on the 3rd floor of the G block to create 2 wards. We already have 1 ward on the ground floor. And I'm thankful that the engineering department cooperated with me in completing the major renovation of B ward in record time. And this included a complete overhaul of the firefighting system and all other facilities, which I could then hand over to Unit 2. And now we have a fully functional Ward B, out of which the Unit 2 operates. Of course, the Unit 1 continues to operate from Ward A on the ground floor. That's because the renovation of Ward in Tower A on the 3rd floor is still pending. And I'm hoping that we'll be able to complete that soon, and we'll be able to shift completely to the 3rd floor. Even though a number of permanent and some contractual faculty members in the department, the number has come down recently as some of our colleagues left the institute, either taking voluntary retirement or having completed their contractual tenures. My colleagues and I have been able to ensure that this has had no impact on the quantum of clinical and academic work or their quality. Rather, there's been a consistent increase in the patient numbers in almost all disease areas that we cater to. Some of our senior nurses have also retired, but then we have inducted a whole set of fresh, enthusiastic ones too, who are now providing services to our patients. Another significant event which has occurred recently is, after a long hiatus, we have now initiated the process of recruitment of regular faculty members. The number of inpatient beds, they have increased from 34 until last year to 60 now, out of which 52 are functional, and we hope to make the rest of the 8 functional too. And the daycare beds that are available to us for our patients has too increased from 8 to 10. Of course, in order to operationalize the new ward, we had to have a whole set of new nurses, and I'm thankful to the Institute administration for giving us 19 extra nurses for the wards, and we have 2 extra nurses available for work in the OT. The number of technicians in the department has gone up, and we also have been approved a 3rd major operation theater. I'm sure all of you who have worked in this department know we have been working out of 2 major OTs and one minor OT, which we continue to use to full extent. And only recently we have completed the renovation of our 2 existing major OTs. In addition, we also utilize 1 session per week in the robotic surgery operation theater. There were a number of niggling problems relating the equipment procurement and maintenance, and with immense help from my colleagues in the department and from the material management department, we have now been able to start the process of repair and procurements of majority of these, but this is an ongoing process which must go on. So our department operates out of various locations, the outpatient clinics that we run in the OPD building, which also houses a minor OT, ultrasound room, minor procedure room, the dressing room, our office spaces in the library in the department, the 2 wards that I talked about just now, the laboratories in our department, and of course, out of our nerve center, which are the operating rooms. So this department has been fortunate. From the very beginning, there's been a focus on quality and satisfaction of all involved. I've inherited a system of good administration and governance, which I'm trying to continue, and my colleagues have insisted and have ensured that this is continued. And this we do by adopting a system of shared decision-making and shared responsibilities. All my colleagues in the department, in faculty, they shoulder responsibilities of both administration and governance as the faculty in charges for resident rosters, academic schedule, and they look after and maintain the OPDs, the wards, OTs, etc. We have insisted and ensured on working on a system of equal rights, equal opportunities, equal responsibilities for all. And I'm happy to say that this system continues to work, though recently we have added a few more initiatives. We have recently completed the exercise of preparing an overhauled competence-based curricula based on the guidelines provided by the NMC, both for our MCH endocrine surgery program as well as the PDCC breast surgery program. The recent Board of Studies approved that, which was subsequently approved by the Academic Board of the Institute, and the Institute has now forwarded this to the National Medical Council, National Medical Commission, for its approval and inclusion as a model curriculum. We have also introduced, and we are using routinely, an objective academic performance and attendance monitoring for our residents. So, as I said, the nerve center, or the main focus of our functioning, is our operative work. And we continue to offer clinical and operative services to a whole spectrum of endocrine and breast surgical disorders. And this includes close collaboration with various other departments and disciplines. And I must thank and appreciate the cooperation I've received, and all our colleagues, my colleagues have been receiving from various collaborating departments, including the anesthesiology, urology, surgical gastroenterology, and certain others. We've been able to work because we have a great team consisting of endocrinologists, radiation oncologist, nuclear medicine physicians, and recently medical oncologist, and other specialists in the institute. And so I must I must thank all the faculty members and the heads of departments of these various departments who are present here, or even those who are not here today. In the recent years, we have had increasing number of patients who have been supported by government financial schemes, including the PMJY Ayushman Bharat scheme, the Pandit Deen Dayal Upadhyay scheme for government employees, as well as the CM and PM discretionary fund. And I would like to draw attention of our honorable chief guest, sir. Sir, just to re-emphasize to you that this institute is a paid hospital where the patient has to pay for every service required. And at certain stage, it used to be considered as difficult place for poor patients to come to and get treated. But this is changing. We now have a substantial proportion of our patients who are being supported from Ayushman Bharat scheme and various other government of UP and government of India schemes. And we now have a substantial number of poor patients being treated here. In terms of the new registrations in the OPDs, in the recent year, we have had a substantial increase. If we extrapolate the data for the first 8 months of this year, we would certainly surpass the data relating new patients registrations, the follow-up patients being seen in our OPDs, the admissions we do in our wards, as well as the operative procedures we perform for various indications. And this comes as no surprise because I'm blessed with a team of excellent surgeons and committed faculty members and residents who toil day in, day out to not just maintain the quality, but also to increase the number of patients that we take care of. Now, just quickly go through the various disease areas that we cater to, benign thyroid diseases. And one factor that you would see consistently is in the recent year, we have had increasing number of these cases. Differentiated thyroid cancers, the medullary thyroid cancer, anaplastic thyroid cancer has come down, and that's a welcome step. Parathyroid surgeries, adrenal gland, including pheochromocytomas and paragangliomas, benign breast disorders, carcinoma breast, diabetic foot. These are the various things that we cater to, and consistently in each of these spheres, the numbers have gone up. One focus of our department has been to offer high quality contemporary surgical procedures to our patients. And minimal access surgery offers a whole a new paradigm of heightened or better patient outcomes for our patients. And so we have had a similar focus in this area. Endoscopic thyroidectomies by various approaches, endoscopic parathyroidectomies, minimally invasive parathyroidectomies, video-assisted thoracoscopic thymectomies, laparoscopic and retroperitoneoscopic adrenal surgery, and pancreatic surgery. These are what we do routinely, and I'm happy to say that we've been consistently doing well in this area. And one new area, new facet which has been added in recent years is the robotic endocrine surgeries. And what has changed in the last 1 year is that we are now conducting these procedures routinely without any proctorship or without help of any external expert, because one of our colleagues, Dr. Gyanchand, is fully trained in this area, and he's now ensuring that the training of rest of the faculty members and residents is also carried forward. So the whole spectrum of surgical procedures that we perform, they come with use of numerous new technologies. And there's been a consistent focus on upgrading our armamentarium, our devices and gadgetry. And this we use, there are various technologies that we use. We use intraoperative PTH monitoring, intraoperative neuromonitoring during thyroid parathyroid surgery, oncoplastic breast surgery, totally implantable venous access devices, image-guided wire localizations, sentinel lymph node biopsies, image-guided biopsies and vacuum-assisted biopsies, and various other new technologies which are appropriate for use in endocrine and breast surgery. And I would reiterate, we are able to do what we are able to do, what we are doing, primarily because we have such a fantastic cooperation and help from various other disciplines, including radiology, CBTS, and various other departments. And I really wish to thank each one of them for this cooperation. Shifting gears quickly to tell you something about our teaching and training activities. We have had this system of structured mentor teaching and training of every training forever, and this continues. The mentor supervises and monitors the academic and research activities of the mentee, and each resident, each mentee is allotted one mentor from the faculty. There is a comprehensive academic program covering all facets of endocrine and breast surgery, and this is in form of various sessions, including journal clubs, case presentations, seminars. And one important aspect of our teaching training has been the multidisciplinary flavor to our teaching and training. The interdepartmental sessions, interinstitutional sessions have been extremely beneficial for our trainees, and so are the multidisciplinary tumor board meetings that we learn from. We conduct an induction program to prep all the newly joined residents. This includes preparation for their not just patient care and academic and research protocols, but also introducing them to the work ethics and research ethics while they're working in the institute. All residents, they maintain a logbook of not just clinical and operative work, but also of the academic and research performance. And we conduct midterm and preparatory examinations, focusing especially on the areas of deficit. Currently, there are 11 MCH students training with us. There's one PhD student enrolled in the department, and there are 2 research associates or JRFs. We currently have Dr. Von Wosen, who is a trainee surgeon from Ethiopia, who's training with us for 1 year. We have had other short-term trainees, and we are about to be joined by a trainee surgeon from Armed Forces. We have been conducting numerous small and big CMEs and continuing nursing education programs throughout the year. This is to show you some of the recent training activities for our residents and trainees. We've conducted a robotic surgery training program for them. We have conducted other endoscopic and suturing techniques program for them, and numerous others. We have not lagged behind in terms of research output as well. To date, our department faculty have carried out 32 extramural grants, and currently 4 are ongoing, and there have been at least 70 intramural grants conducted by various faculty members. Currently 7 are ongoing, and the value of the currently ongoing extramural grants is close to 220 lakhs. So far, we have had some 600 publications emerging out of the department, and in the recent year too, we have had 22 publications in peer review journals and 6 book chapters, and many of these publications are frequently cited, and the faculty members in the department have, majority of them have very high impact factors. The H index of one of them is 46, and one of them has featured in the top 2 scientists in the world list of 2020 year. Our faculty are much sought after speakers in national and international meetings, and it comes with as no surprise that more than 40 invited lectures and orations have been delivered by my faculty colleagues and me in the current year. Our residents, our junior colleagues in the faculty, they have all been consistently presenting their work in various conferences and symposia, and many of, or rather all of them, have been awarded with best paper awards, travel bursaries and awards, and certain other awards and accolades. The department also conducts a string of breast cancer awareness events throughout the year, and more so during the Breast Cancer Awareness Month, that is October. The SGPGI Breast Health Program has conducted close to 2,000 breast cancer awareness events ever since it came into inception in 2001. And this year was no different. Besides breast cancer awareness, we also carry out awareness programs for diabetic foot awareness, thyroid cancer awareness, and various others. In recent time, I had the good fortune of delivering a TED Talk where I focused on the importance of early detection and comprehensive treatment for curing breast cancer. We are a friendly bunch of people. We have believed and have been fortunate to enjoy each other's company. We believe the department that celebrates together grows together. And I'm happy to say that in recent months, these events have become rather too frequent, but I'm not complaining. So let's keep working in this friendly spirit, collaborative spirit to achieve more and more. Finally, I wish to thank each one of my faculty colleagues in the department, Dr. Anjali Mishra, Dr. Yanchan, Dr. Sabaratnam, all the assistant professors, all the residents in the department, and each and every member of the department, may they be nurses, the paramedical staff, the office staff, and various other support staff that we have. And I'm happy that we are progressing as a team. And I wish all of us continue to do so. Thank you very much.
Thank you so much, sir. May we be as courageous and innovative as our teachers to carry forward the legacy of this department. May I now invite our respected director, Professor R.K. Viman, sir, to bless us on this auspicious occasion and deliver his address.
Good afternoon. Professor Vijay Ojha, the President, Postgraduate Medical Education Board, NMC. Professor Shalin Kumar, the Dean, PGI. Professor Gaurav Agrawal, HOD. Sabaratnam, Organizing Secretary. Dear colleagues and foreign faculty that I have seen over here, you are all welcome. Delegates, ladies and gentlemen. It's really a privilege for me to be the part of this function, that is 34th Foundation Day of the department. And I'm also glad that these foundation ceremonies are being conducted by most of the departments, and it gives an opportunity to look at what we have done in the past few years, particularly in the last year, and what are our planning in the coming year also. And we have heard about the annual report that is very impressive by Professor Gaurav Agrawal. Myself and Dr. Ojha was colleague as far as the NMC National Medical Commission Postgraduate Medical Education Board is concerned. But now he is presiding the same board. So I will be talking about the institute rather than the department and draw his attention how this institute is also expanding. When I'm talking about the expansion, so I'm talking about the expansion each and every level. I'm happy to tell you that there are the 4 new centers are coming up to PGI, 4 new departments are coming up also, and the robotic surgery is given preference also. Out of these 4 centers, I think you have visited one, that is the emergency medicine and the renal transplant center, and our Professor Ansari, head of the department of urology, was accompanying you also. And you must have appreciated the development that has been done in urology as well as in nephrology, not in terms of the beds also, the facilities also, but the curriculum and the other things also, and the research also. Nephrology has started the interventional nephrology also. And the most important thing and fascinating thing that I would say, the Dr. Ansari's love towards the pediatric urology also. And once the ward was vacant, then we immediately allotted that ward to Professor Ansari to take care of the pediatric urology. If we can have the pediatric nephrology, certainly we can have the pediatric urology. And each month, at least I am getting 2 or 3 references for the children requiring the urology attention. And I am referring them to the Dr. Ansari and his colleagues also. That is the need of the pediatric urology. I personally felt in this institute also, and we have given him the 30 beds, and whatever he wants, equipment wise, we are ready to give it also. Similarly, we have given 30 beds to the pediatric nephrology also. So that is the center that I am telling you. In addition, we have the emergency medicine over here, 210 beds. Existing 30, we increased to the 2 units, 60. Now we are expanding it to the 210, that is the 7 units also, to cater the need of the emergency medicine services in this institute also. The second thing, I am promoting pediatrics. There is no doubt about it. I am not a pediatrician, but still I am doing it. Why I am doing it? The 40% of the population of the UP is pediatrics. That is up to 18 years of the age. And we need an advanced pediatric center, not only for the patient care also, but also for the teaching, training, and the research, cutting edge research in this. It is neglected part. Pediatrics is neglected. But once we see wherever the pediatrics are available and there is a queues and there is a huge rush, that means that we have the patient, they need to be given that care also. I give you another example. We have Professor Vijay Lakshmi Bhatia here also. She is the professor and head of the department of the endocrinology, but she is looking after the pediatric endocrinology. You just go to his OPD and see her patients also, they require, particularly the insulin-dependent diabetes mellitus. And she has not concentrated only in the institute, but she is expanding into the outreach programs also, so that in remote areas, the patient, so this is the beauty of these units, not only confining to the SGPGI, but going out for the outreaching programs also. So for this 40%, we are coming up with the Advanced Pediatric Center. And I am really grateful to our Honorable Chief Minister, Yogi Adityanath ji, who has consented to come with a center of 573 beds, 22 departments, and the 2 units, with all research facilities and everything. So, for example, we have the neurology, we will have the pediatric neurology, pediatric neurosurgery, pediatric CVTS, pediatric urology, everything. And in addition, we will be having the pediatric department also. So, we are developing, now we are developing these specialties which are not existing, but we have the patient, we have the facility. So, here comes the role of the NMC, particularly you, sir. Another thing, I'll give you another example of the congenital heart disease. Congenital heart disease, 70,000 persons in UP, which has the population of the 25 crores, they are born with the congenital heart disease, and not even a single center where they can be treated. So what we have to do? We have a couple from California, Mr. and Mrs. Sept. They lost their child at the age of 13 years suffering from the congenital heart disease, and they are doing their best that a center at SGPGI should come up, and they have also promised to donate $50 million, 480 crore rupees, with a 200-bed state-of-the-art Center of Excellence for the children born with the congenital heart disease, just like in the Stanford also. And out of these 200 beds, 100 would be the ICU beds. And what is the ultimate thing, that it would be ready by 2027, and we will be operating at least 5,000 surgeries or doing surgeries every year also. I think that would be a boon to the children born with the congenital heart disease in the state of the Uttar Pradesh. So we are progressing, we are expanding, not without any aim, but with the aim that we have to serve our children, these children also. So we are coming with it also. And the another center that we are coming up is the Advanced Diabetic Center. This is about to start in the month of the December this year only. Just to say that most of the time, our patient with the complication, they used to go to the south. Our Honorable Minister said कि no patient बाहर नहीं जाना चाहिए, सबका इलाज जो है उत्तर प्रदेश में अवेलेबल होना चाहिए. Then we have the 2 floors, this center also, providing the all kind of the care to a diabetic patient, including the eye care, renal care, or the diabetic foot also. So I've told you these are the centers that we are having now. And similarly, we are expanding about in the direction of the departments also. We have seen the COVID, and we realized, the government also realized the importance of a department of the infectious diseases over here. So we have already allotted the 40 beds, including 10 beds with the ICU to the Department of the Infectious Diseases. And we are also for the pediatric endocrinology also, and you remember that we applied for the DM in pediatric endocrinology, and I am hopeful that we will get the positive response from the NMC also. The another department is the head and neck surgery also. We are coming with it, and robotic surgery I have told you also. What I'm trying to say that the expansion is not haphazard. It is a planned expansion of the SGPGI. Initially, we were having 609 beds. After this emergency medicine, we have the 2167 beds. And after these centers, we will be having the 3100 plus beds. So it is a very much, I would say, the expansion in the right direction. But patient care is fine, and the patient care cannot be without the faculty, without the residents, and without the research care also. Residents only join when they get something in return. And for a student, what he or she wants, a degree, it may be the PDCC, it may be the PDF, or it may be the DM and MCS. I think the opening of the Advanced Pediatric Center and the Congenital Heart Disease Center, I would say it will pave the way for the new specialties that is really required. We will be the first, as we were the first when we started the surgical endocrinology. We were the first when we started the medical genetics, and we were the first when we started the immunology, clinical immunology also. And so you all know the SGPGI, the mandate is the tertiary care only. When it was started, everybody was have the doubt whether it will be successful or not. It's straightforward, starting with the MCS, DM, but you know that we are 7th in whole India NIRF ranking, and if you take only the northern India, we are the 3rd, just after the AIMS Delhi and the PGI Chandigarh. And sir, with your blessings, I expect that we will be hopeful to fulfill our dreams. I wouldn't say not my dream, I'm saying our dreams. All these people are looking after that dream. Thank you so much.
Thank you, sir, for your kind words and valuable guidance. We are privileged to have Professor Vijay Oza, President, Postgraduate Medical Education Board, amongst us, who has kindly consented to be the chief guest for today's function. May I request you, sir, to kindly deliver your inaugural address.
Respected Professor Diman, Director, SGPGI, Dr. Professor Salim Kumar, Dean, Dr. Agrawal, Dr. Sabaratnam. Previously, I was just looking at your name and then I say how to pronounce it. But then once he said that he is Sabaratnam, then I say he is from place where I belong to, means right now. Though I belong to North Gujarat, means I belong to Gujarat, but since last 30 years I am in Pondicherry. So then after मुझे लगा ये तो अपने वाला है. So then I thank and then all dignitaries and friends. I thank Professor Diman to inviting me in this very prestigious institute, and it is really an honor to be invited in a institute of such a repute. It's a lifetime honor. I thank you for doing that for me. regarding the possibilities of further developments in the specialities, I have very few things to say. That evolution is a rule of nature. Whatever we do, whatever we try to prevent, things are going to evolve. And it is evolving. It is part of the nature. And that is why various specialities and subspecialties are bound to grow. Even if we do not wish, it is going to grow. And if we actively participate in the process of evolution is yoga. There is nothing, yoga is nothing different. It is not closing the eyes and just sitting silently in the things. If you participate, or if we participate in the process of the evolution, the nature is doing as a routine. If we actively participate in that process, is yoga. So, आपके जब when the आपके योगी जी यहाँ हैं, so this evolution is very much active in this part of the state, and I am very happy that you have a director and even the dean of such a enthusiasm. The person who is here for a temporary period as such, but he feels this institute being a part of his own, as if he is born and brought up here and is going to be lifetime director here. That type of a love and affection he has for this institute. I admire you, sir. And obviously, the institute has grown a lot in your tenure, and it will definitely grow. From my side, I have already conveyed you that the developments and newer things are going to happen. NMC will never come in the way. Whenever there is a capacity for somebody to develop some newer things, obviously we have to encourage them. We cannot, even if we stop it, it is not going to be stoppable, because those who establish their capacity and show their worth, probably it may be 1 or 2 centers in the country, but tomorrow everything started as 1 or 2 centers in the country everywhere, and then only it has grown. So it is going to grow, and we are there to help everyone. And regarding the any other things, obviously I would say that we have now those who are doctors here. Obviously, they must be interested in lot of NMC things, but if I speak from my heart about the NMC, then there will be a lot of controversy. So there will be a social media will deviate and all the things. So I'll speak from my mind only, and I say that we are trying our best. Whatever probably the news about the some things about this and that are sometimes they may be true. The government is investigating. But we are working under the able leadership of our Honorable Prime Minister and Honorable Health Minister, the best possible National Medical Commission for the years to come. And Professor Diman is one of the examples who was the foundation, who has laid the foundation along with me for the post-graduation, and my best wishes for the institute. Thank you.
Thank you very much, sir. I request our director to felicitate Professor Vijay Oza and hand over a memento. Thank you, sir. We are joined by our Foundation Day orator, Professor Ashok Shah from New York, and I request our chief guest to hand over a memento to him, which will be accepted on his behalf by Professor Gaurav Agarwal. We are also joined by the Department Breast Surgery orator, Professor Owen Hung from Brisbane, Australia. I request the chief guest to hand over a memento to him, which I request Professor Anjali Mishra to accept on his behalf. We shall ship these to you, sirs, in the coming days. The keynote address of the 15th PG course in endocrine surgery will be delivered by Professor Jin-Wook Yi, who has traveled all the way from Incheon, South Korea. I request the chief guest to hand over a memento to Dr. Yi. I request the head of department, Professor Gaurav Agarwal, and organizing secretary, Dr. Sabha Ratnam, to hand over a memento to our director, Professor R.K. Dhiman, and the dean, Professor Shaleen Kumar. Thank you, sir. On the 34th Foundation Day of the Department of Endocrine Surgery, it is our great privilege and pleasure that Professor Ashok Shah from Memorial Sloan Kettering Cancer Center has agreed to deliver the Endocrine Surgery Foundation Day oration. I request Professor Gaurav Agarwal to introduce Dr. Shah, who has joined us via Zoom.
Dr. Shah, am I audible to you?
Yes, very well.
Good morning to you. Good evening from Lucknow.
Thank you.
So we come to that section of the program now where we would have two orations. And before we start these orations, may I take a moment to pay tribute to a couple of outstanding, path-breaking endocrine surgeons who departed for the next life only recently. Professor Tom Reeve, my mentor, under whom I did my fellowship. He passed away just about 3 weeks ago, and so did Professor Blake Cady from Leahy's Clinic in July this year. And these are stalwarts who created the specialty of endocrine surgery, and I thought this will be an appropriate moment to pay tribute to them. And I'm sure Dr. Shah would agree with me that we all owe a lot. We all, us endocrine surgeons, owe a lot to these stalwarts. So, ladies and gentlemen, it's my proud privilege to introduce to you the 2023 Endocrine Surgery Foundation Day orator, Professor Ashok R. Shah, whom I, just like most endocrine surgeons, consider a role model, a mentor, and a friend who never disappoints. Dr. Shah has joined us today from his Manhattan office in the Memorial Sloan Kettering Cancer Center, New York, USA. Dr. Shah is an attending surgeon on head and neck services at Memorial Sloan Kettering Cancer Center, the Alan H. Selig Chair in Head and Neck Surgery, and Professor of Surgery at the Cornell University Medical College, New York. Dr. Shah completed his surgical training in Baroda, India, and worked as a house surgeon at the Tata Memorial Hospital before he moved to USA to train firstly at the Downstate Medical Center in Brooklyn and then at the Memorial Hospital. He joined the Department of Surgery at Downstate Medical Center in 1982 as a head and neck surgeon, rising to the rank of Professor of Surgery in 1992, and then moved to Sloan Kettering in 1993. Dr. Shah is a highly decorated surgeon scientist. He has, to his credit, several gold medals during his training and subsequently. And in fact, if I read out only just the most significant prizes and awards that he has received, it will take minimum of 10 more minutes. And I'll have to skip that. Dr. Shah has been bestowed with numerous awards, medals, by almost every head and neck surgery and endocrine society across the globe. He has been a visiting professor to some of the best universities and hospitals globally, and has been the president of American Head and Neck Surgery Society and the American Association of Endocrine Surgeons. And that's a rare honor for any surgeon, being a president of both these amongst the most significant societies globally. He has delivered numerous prestigious orations and is a popular speaker at conferences across the globe. And may I add, with his great sense of humor, there cannot be a dull moment when Dr. Shah takes the center stage. And I'm sure you will appreciate that when he speaks today. And it comes as no surprise to me that he has delivered more than 2,000 lectures and talks across the globe. Dr. Shah, he has been on the editorial board of some of the most prestigious scientific journals. He has published more than 150 original papers, and every endocrine surgeon sitting in this hall cannot but appreciate the kind of work he has done. Some of his seminal papers are cited on a daily basis by each one of us, whether we are in our clinics or in the academic sessions. He's been the chairman of the Advanced Training Council of Head and Neck Fellowship in the United States for 10 years. But to my mind, the greatest contribution Dr. Shah has made has been in form of a teacher and a mentor to a whole generation of head and neck and thyroid surgeons. And so I think it's most appropriate that he has chosen to address the issue of training of thyroid surgeons today in this oration. Ladies and gentlemen, I give to you Professor Ashok R. Shah, the 2023 Endocrine Surgery Foundation Day orator.
It's a great honor and great pleasure for me to present this talk on training of the thyroid surgeon, which to me is probably the most important. The great honor and special pleasure for me to present this talk on training of the thyroid surgeon, which is probably the most important concept in the management of endocrine surgery. And I must give credit to many programs in India who have developed endocrine training. I would like to bring greetings right at the outset from the World Associated Cancer Center. This is our new outpatient surgical unit, a state-of-the-art facility. I would also like to bring greetings from New York City. Things change after 9/11, but we have come back to almost normal life. This is a new Freedom Tower, and you happen to be in New York, please do visit. The observatory is outstanding. You will just love this place. So I always like to show some of my algorithms, which are very popular. Only 20% of you will remember 20% of what I said 20 minutes after my lecture. So the memory span is very small. So we're going to forget everything what we said tomorrow morning. And that's why the meeting is generally 3 days meeting. On the third day, you forget what was said on the first day. So the issue is why we discuss the training of a thyroid surgeon. And there are many reasons behind it. Clearly, endocrine surgery has become a mainstay of specialty in the general surgery. And the reason is there is a higher incidence of thyroid cancer. In the United States, we almost perform 200,000 thyroidectomies every year. The biology of thyroid cancer is much different than other human cancers. This is not a pancreatic cancer. This is not a brain tumor. I call this a friendly enemy. And that's very interesting to consider that the biology of thyroid cancer is much different. At the same time, even though it is a friendly enemy, there are types of enemies who are very aggressive, and our responsibility as a good thyroid surgeon or a well-trained thyroid surgeon is find out who are the patients with thyroid cancer who are likely to get into trouble. There is emerging technology, and I'm sure you are going to hear in the next 2 days about the robotics, endoscopic, transoral surgery. So one thing I want to bring up right at the beginning, the complications of thyroid surgery is so minimal. They are most serious problems. Just imagine a young girl with permanent hypoparathyroidism or a surgery with overbought paralysis, life changes. Clearly, there is a over-diagnosis and over-treatment. And what is important in the management of thyroid cancer is the first procedure is the most important for cure of the patient. And if you want to take care of the patient with thyroid cancer, go from A to Z. This is very important. Now, I just want to show you this slide. Many years back, I presented this with a huge thyroid. The airway which is barely 2 or 3 millimeters. And the problem starts operating room because the anesthesiologist tells you, be prepared to do tracheostomy. No way, Jose, you can't do tracheostomy. You can intubate this patient very well without any problem. For a patient presents a test with large tumor, paralyzed vocal cord, what do? I tell them go from New York to Lucknow. There is a great endocrine center there, and Dr. Agarwal will take care of it. This is a difficult problem. The chances of this patient's recurrence is very high. Local recurrence, nodal recurrence, and distal recurrence. So we have come a long way. We started from focus, particle science, to now the robotic surgery. Things have changed quite a bit, and that's why I always like to go from poker to Shanghai or from Vienna to Seoul, Korea. Things have changed quite a bit. Now the training of poker was a great surgeon, the biology, but more importantly, a great teacher. He taught several amazing thyroid surgeons, including Harvey Cushing, William Rockdale, William Mayo, and they all became the greatest of the great be my responsibility and good opportunity for me to speak to two of the greatest heroes of God and many endocrine surgeons around the world who we saw in the last year and a half. One was Katie from the clinic and the other was Overall Clark. Now keep in mind, the philosophies of these outstanding teachers and surgeons were quite different. One was strong proponent of lobectomy, one was strong proponent of thyroidectomy. However, what we need to realize, the outcome was the same. The debate in thyroid surgery goes on because the outcome is the same. Now their contributions are extremely well recognized, and that was through Congress. The PGES that is the name of endocrine surgery. And these two giants in thyroid surgery represented their utmost respect to their colleagues, to their passion, to their profession and passion. That is important. So you can't do a talk without showing something from the New York Times. There are two slides you must have, one from New York Times and the other from New England Journal of Medicine. So this was a write-up in 2014, an epidemic of thyroid cancer. Now, why am I showing you this? Not only there was an epidemic, but my name was quoted in that. And, there's a greatest joy when your name is seen in New York Times. Now, at that time, or even before that, about 10 years before that, I made this slide. And I called it not epidemic, but I called it pandemic. And truly now we realize that the thyroid cancer is a pandemic of disease. I always like to show you slides just to give you the idea how much PubMed literature is available. Now that is perfectly okay. It's the same I'm going to write again and again. But look at the Google site. There are 647 billion sites on thyroid cancer. Now, when we talk about the meaning of the thyroid surgeon, there are 4 issues I'm going to address. Who should be trained? Who should perform thyroid surgery? Or the simple word, whose domain it is? The next is standardization of the training, both of the surgeon and the fellowship. Impact of technology, that's what I call scalpel to robot, and the most important responsibilities of the banker and vision for the future. Where do we see ourselves as a thyroid surgeon and as a banker in future training thyroid surgeons around the world? For years, thyroid surgery was dominated by general surgeons. Why? There were territorial disputes, the referral patterns, and most important, there was an underlying issue of finances. The head and neck surgeons, there are 2 groups of surgeons, the head and neck surgeons and the endocrine surgeons. The head and neck surgeons are better trained in oncologic surgery. Do they understand 100% the biology of thyroid cancer, the ultrasound, etc.? That is something we will be trained in near future. Now keep in mind, in the past, head and neck surgery was also dominated by general surgery. For the last 25 years, things have changed in the United States. Almost 80% of the head and neck surgery is now done by otolaryngologists, and only 20% is done by general surgeons. Now there are certain critical aspects of thyroid surgical training, complex issues, as I mentioned before, management of recurrence. Anybody can take care of a surgery with a thyroid cancer. But the problem comes when there is a recurrent disease in the cellular compartment, adherent to recurrent that is reserved. Complications are very important. Common surgery, but serious complications. And today, the whole panorama of management of thyroid cancer has changed with the understanding of the molecular markers-based treatment or targeted therapy, and more importantly, our major advance that we have made in the last 3 years is the understanding of the biology of the aplastic thyroid cancer, the re-rehabilitation, and most important is the mutation-based treatment. One of the most disastrous human disease, plastic cancer, where the average survival is 3 months, is now extended to 3 to 4 years. And I think this is a major change in the management of thyroid cancer. Remember, good judgment comes from experience, and experience comes from bad judgment. Thyroid cancer is a surgical disease. Myself here and my colleague, endocrinologist, Dr. Thomas. Now remember, he does not rate any complications. Endocrinologists are generally the most aggressive thyroid surgeons in the world because they don't have to look for the nerve or the parathyroid gland. So let's just go back to the history about the performance of the number of thyroidectomies by general surgery lately. This is one of the landmark papers published in 1995 by J. Horvath. The average number of thyroidectomies performed in general surgery clinic was 12 to 13. This is a small number to train somebody or to be called as a thyroid cancer expert. Things change in 25 years, and now you take a look. This is a paper by Rebecca Simmons, and she showed that bulk of the thyroid surgery is done by ophthalmologists. You can see here the average experience of a chief resident in year 3 was 50 thyroidectomies compared to 20 in general surgery. So why there is a domain issue? As I mentioned before, multiple specialties that exist in thyroid surgery, the general surgery, the ophthalmology, the surgical oncology, medicine, surgery. There is clearly a reference pattern, the reference from general practitioner or the endocrinologist. Experience and expertise is very important. And most important, financial issues, and there is always a prejudice and ego. And this is very important in surgery. Prejudice and ego lead to territorial disputes, financial issues, and advocacy. Now, let's look at the thyroid surgery, the training of the thyroid surgery. It can be the background of general surgery, otolaryngology, even pediatric surgeons, surgical oncologists, and then you have our 2 major groups, the anesthetic surgeon and the endocrine surgeon. Let's analyze each one of them. Otolaryngologists, they have limited experience, they don't have huge experience. They can do a small thyroidectomy, but when it comes to understanding of the biology, the controversy, and overall management may be very difficult. But remember, they are the main gatekeepers. If you go to the otolaryngologist for any anesthetic problem, they will examine your thyroid, their ultrasound, and they are the first line of evaluation of incidental lobe. What about the surgical oncologist? Well trained in surgical oncology, but immediate training in anesthetic surgery and immediate training in thyroid surgery. They do understand the biology of the disease, but they put it in the equation of other surgical oncology issues. Now, this is what we don't want. The Sept associated incidental neoplasm, what we call as pain, they is very often compared to any other specialty. Let's look at the thyroid surgery as a general surgeon or otolaryngologist. Now, the anesthetic surgeon who will be trained from general surgery, which is about 20% now, and otolaryngology, which is about 80%. They may be a little different in India, but this is the practice in the United States. But the anesthetic surgeons are quite familiar with the management of the central compartment, the larynx, the trachea, the vocal cord. They can manage the trachea very well, and they do understand the controversy because that's what they have been trained during their fellowship. Let's look at the endocrine surgeon. This is clearly a new specialty, and I've mentioned many started here in the United States. Clearly now is the endocrine specialty. There is good experience and expertise. There's great teachers, and I show you the 2 great teachers, like Gary and Orlo Clark. The limited number of surgeons, unfortunately, the training programs are producing approximately 30 to 40 endocrine surgeons. They are not very familiar with neck dissection and vocal body cavitation, and sometimes they will need help for tracheal dissection or reconstruction. The head and neck fellowship is well known in the United States for a long time. There were two background societies. The Society of Head and Neck Surgeons, dominated by general surgeons, and American Society for Head and Neck Surgery, dominated by EMC. These were merged together in 1999, and I was very fortunate to be the co-president of the year, in the year it was founded. Currently, there are approximately 42 programs of head and neck fellowship and 52 positions. Out of these, there are 4 dedicated to endocrine surgery. This is through head and neck surgery. Let's look at the different perspectives. In this head and neck fellowship, about 40 to 50% of the volume is related to thyroid surgery. The number of thyroidectomies performed in the United States has gone through the roof. And these head and neck surgeons are quite familiar with the neck dissection, tracheal dissection, and rarely their injectors. Let's look at it different angles now. Endocrine fellowship. This was started by American Association of Endocrine Surgeons. The formal endocrine fellowship started in 2005, and the batch started in 2007. Today there are 27 programs training approximately 35 candidates. Now I have to credit to your group in Lucknow who started MCA endocrine surgery back in 2004. Congratulations to the entire team. We have program in India, which is much ahead of other programs in the rest of the world. Now, I was asked back in 2001 by John Watkinson from Birmingham, England. He asked me to give a talk on thyroid surgery, the domain of both, in front of John Arnold and Malcolm Wheeler. And take a look at the statement I made at time. Thyroid surgery is the domain of a well-trained thyroid surgeon. Irrespective of the background specialty, it's the domain of a very specialty, but the domain of a well-trained surgeon. It should not be the issue of very specialty. It doesn't matter whether you are a general surgeon, rheumatologist, pediatric surgeon, as long as you are a well-trained thyroid surgeon, you should be able to master the technique. Now, what is our responsibility in the training program? There has to be a core knowledge, anatomy, pathology, biology. Clinical expertise is undoubtedly very important. Expertise is not only in the surgical technique of thyroidectomy, of pathology, but the radiology. Understanding of the prognostic factors and risk groups is very important. Judicial application of your technology. Thermal monitor, robotics, laptops, and robotics. Very important. And as I mentioned before, understanding and evaluating for accurate treatment. The medical oncology has become a sub-specialty in endocrine surgery today or endocrinology today. The fellowship is 1 to 2 years, depending upon your research interest. Spend some dedicated time in thyroid surgery. After the fellowship, go around the world, maybe in your own country or different parts of the world, to see the perception of thyroid surgery around the world. You must be expert in ultrasound, you must be expert in ultrasound biopsy, and as I mentioned before, understanding of the biology of thyroid cancer. The educational activities are very important for endocrine surgeons. Endocrine conferences, thyroid fever boards. You should have a picture both locally, nationally, and internationally. Who can teach out for not only complex problems, but advice and decision making. You must get involved in the clinical and basic science research. If you want to be ahead of the game and at the top of the leadership. So let's just summarize. The training of a thyroid surgeon can be through surgery or pathology. There is a board certification. Then you can do enterprise fellowship, AES 3, like you have one now, or the health fellowship, that you have already fellowship. And then you can do the international fellowship around the world, depending upon your interest. You can go to South Korea, or to Thailand, or to Japan. Again, ultrasound, feedback, robotic thyroidectomy, these are the nuances in the management of thyroid cancer, and we should be very familiar with that and decide what applies best to your patient and your institution. I'm quite fond of this slide. This is from Jack Lorraine, the famous thyroid and head and neck surgeon from Buffalo. He called different terms for the low and high volume surgery. So he used the word dabbler. Dabbler means superficial care. Just doing little bit, not in the depth, not A to C care, but A to C care. That's what's good in the management of thyroid cancer. So he divided the low and high volume surgeons for their dabblers. Low and high volume institutions for their dabblies. And the complexity of the procedure, low and high complex, can be called as dabblage. I'm very happy to see this slide and the wisdom of Jack Lorraine. We are always in search of an ideal surgical procedure. We have been doing this since the beginning of the last century, since over teaching. Modern technology will turn a third-class surgeon into a second-class one, but will never turn a second-class surgeon into first-class. And our responsibility as an endocrine surgeon is to be the first-class one. New implications of technology, nerve monitor, we can go into detail, and I'm sure you're going to talk about this for the next 3 days. The robotic surgery, the endoscopic surgery, again, I must go back to the risk group certification, understanding of the biology and the implementation, along with working relations with endocrinology. The most important aspect of endocrine surgery is develop a relation with the ancillary specialty, endocrinology, based on knowledge, the technology. I think these are very, very important ancillary specialties we are important. Endoscopic surgery is minimally invasive or maximally expensive. I will leave it to your best judgment. To be a good endoscopic surgeon, you need to be a better open surgeon. When you see a patient with extremely advanced cancer, where you know the mortality rate is very high, send the patient to a tertiary care center. Send the patient to Lucknow. Don't take care of the patient in a small town because the cancer will haunt you. And this is a classical example. This patient was explored outside the city, inoperable. We took care of this patient 12 years back. It is still alive, doing very well. And that's why I always say, don't get into the lion stage if you don't know how to get out. The previous stage, human, was like the lion stage. And if you know how to take care of the patient, then only jump in this lion stage. The good physician treats the disease, but the great physician treats the patient who has the disease. And our responsibility in training young attendants or young surgeons is to train them to take care of the patient and not the disease itself. The physician is more important than disease. And technology is a master. Remember, the result is disaster. And I want to show you this. The endoscopes and robots are only mechanical tools operated by electricity. The fingers are the best tools as they are connected to the brain. And I think that's very, very important metric of the screening of a thyroid surgery. When we look for the PGES thyroid surgery, this was one of the articles published by J. Margaret when he was president of the AAES about the foundation for future. Develop centers of excellence like one you have in Lucknow. Increase efficiency and quality of care. Most important, decrease the cost. Reduce the complication rate and do your own body. So you learn from your own body where you stand, where your group stands. What is the fellow's responsibility or the trainee's responsibility? Work hard, be honest. I think the most important aspect of being a fellow, number one, be honest, and number two, have a great attitude. Attitude towards your teacher, towards your patient, towards your family, and towards your work. Enjoy the work as a family, and look at the thyroid surgery as a passion, as a hobby. And then you will have the joy of thyroid surgery. So the training of thyroid surgery outside the United States is a little different. In Brazil and other parts of the world, still the thyroid surgery is dominated by general surgeons. Things are being treated quite strictly. There is a considerable interest from rheumatologists of both in the United States and rest of the world about thyroid surgery. We need to work with our endocrinologists and again, as I said before, develop the centers of excellence and develop a thyroid armamentarium. And this is what I call the endocrine armamentarium with the center of excellence and all the specialties directly involved in the management of thyroid cancer. When I was president of the American Association of Endocrine Surgeons, we brought in this word in anesthesia, and this is what we call integrated space. And this is the basic of endocrine. And I call the endocrine society the friendliest of the society. And any new attendee who comes to AES recognizes in a matter of first 10 minutes that this is a most friendly society. That's how I was treated in 1986 when I joined the American Association of Endocrine Surgeons by some of the great inventors of surgery around the world. Now there is a academic ladder in endocrine surgery. Develop interest in endocrine surgery, do the training, do the fellowship, spend some time learning the basic science, and the last, the highlight of the surgical field ladder is getting involved in the national, international societies and be the leader in national endocrine societies or international endocrine societies. IAES is one of those, and there are many organizations both in India and Asia. I just want to show you this slide. This is my favorite slide. Training of the thyroid surgeon. Journey to thyroid surgery is like driving the car. There are four important rules. Have the self-confidence and self-control. You are in the driving seat of life. Select the route, your goal, your destination. Negotiate the roadway, the pothole, the obstacle. Look at the other drivers and stay in your own lane. Check the rear view, which is the past. Pay attention to your surroundings, which is the present, and look through the window, that is the future. And then you will enjoy every moment of academic surgical life. And that's the goal of being a thyroid surgeon and training a thyroid surgeon. There are 3 stages in the life of a thyroid surgeon. The first 10 years you learn how to operate. The next 10 years you learn when to operate. And the most important last 10 years when not to operate. That's
I think you can close it, Gaurav. This is probably the last slide. That's fine. You're muted.
Thanks for reminding me. As they say, this was the most spoken sentence in last 3 years. You are muted. So I just repeated that. No, you just repeated that. What I said was that this was a masterly oration, and usually at the end of an oration, there are no questions, but we have the chief guest in the audience and our dean and some of the senior surgeons here. If there's anyone who wishes to make a comment or anything, a message for Professor Shah, quickly, we are in time, so that's why we can afford to do that. Can we have the microphone if in case anyone wants to make it? But as people gather their thoughts, I must convey to you, there was pin drop silence in the audience, and there was so much interest in whatever you were talking about. And I'm sure with your advice, we'll be able to take our thyroid surgery program and training program further. So thank you very much.
Thank you very much, Gaurav. I just want to congratulate you for your leadership. And once again, I think the endocrine training in your center is par excellence. Now, I mean, you started this way before AES started it. So congratulate to all of you and for your leadership. And I'm sure the products we see from your institution are just outstanding.
You are very kind. I thank you for those kind words, but it also reflects what you said earlier. Endocrine surgeons are the friendliest of all surgeons, and I can see you also wearing the same AAES tie as I am doing now, the friendliest society tie.
Yes.
Thank you very much again.
Thank you.
I now request Professor Anjali Mishra to introduce our next esteemed guest and Foundation Day Breast Surgery orator, Professor Owen Ang from Brisbane, Australia, who has also joined us via Zoom. Good evening, ladies and gentlemen, and I hope we are audible to Professor Owen AU. Professor, are we audible from PGES?
Yes, I can hear you.
Thank you, sir. So it's a privilege and honor to introduce Professor Owen Ang, who is a breast and endocrine surgeon, director of the Metro North Comprehensive Breast Cancer Institute, and program lead for the breast reconstruction at the Hurston Biofabrication Institute. Needless to say, he's a committed clinician, researcher, and educator. And he has been having a very decorated career, during which he has held many affiliations, and some of those are Professor of Surgery, University of Queensland, Royal Brisbane and Women Hospital, Surgical Treatment and Rehabilitation Services, Brisbane, Queensland, Australia. Professor Ang has represented many professional and scientific societies, and he has been Vice President of Royal Australian College of Surgeons. He is President of Breast Surgery International and Executive Member of International Surgical Society. Fellow of Australian Institute of Company Directors, Director of Medical Insurance Group Australia, Director of Specialist Services Medical Groups. Professor Owen had obtained extensive administrative and management experience through his various clinical leadership roles
and representation at numerous state, national, and international levels. He has more than 90 peer-reviewed publications to his credit and is a lead investigator for a number of significant trials of international significance. So I will not come in between you and Professor Wu, and over to you, Professor, please.
Thank you very much for that introduction. If everybody can hear me, I'll just share my screen, and please let me know if you can see my slides. Can you see my slides?
Yes, sir.
All right. So thank you very much for the invitation. Very honoured to be here. When Professor Agarwal asked me to provide this foundation lecture, and he asked me to nominate a topic, I just struggled about what I would talk about. I don't think I can tell anybody in this esteemed audience much more about being an endocrine surgeon. And after that tour de force by Professor Shah, I think he's told you everything about training in endocrine surgery. So I thought in my current role as a Vice President of the Royal Australasian College of Surgery and President of Breast Surgery International, I'd talk about leadership. But, you know, leadership as a surgeon, we're all leaders. I would say the minute you start your medical career, you're a leader. Our college leads surgery in Australia and New Zealand. We are the sole provider of surgical training for all surgeons in all specialties in our two nations. RACS has played a critical role in developing and nurturing leadership in many spheres across medical education, workforce, driving innovation. We set the standard of surgical care in Australia and New Zealand. We accredit all of our facilities and we conduct all the examination. So every surgeon that trains in Australia and New Zealand goes through a single common training program, although we have a devolved training model whereby our various specialties, subspecialties, take care of this technical expertise. But there's more than just the technical, it's more than just the technical expertise. It's also instilling leadership qualities and ethical values, understanding our healthcare systems, and developing leaders who in the future can drive positive changes in healthcare delivery, policy, and outcomes. So, for example, the Lancet Commission recently called for healthcare community to take a proactive stance in advocating for emissions reductions. Climate change, for instance, is just one of the many things that we as a college advocate for, because we as surgeons, and we know the health industry has an enormous impact on global warming. And we're one of the first medical colleges in Australia to sign up Green College Guidelines. We've committed to working with the government on sustainable healthcare, because the health industry contributes enormously to global warming and to waste. And it's something that we as surgeons and as colleges need to be mindful of. And we've hosted numerous webinars and educational podcasts in that area. Now, in Australia and New Zealand, we are a very urban country. Most of our population lives in cities, but we do have vast expanses of rural areas that are sparsely populated. What we know about our community that live in sparsely populated areas, that they have shorter lives, high disease burden, and disparity because of their remoteness. And that is especially so for our Indigenous communities, our Aboriginal and Torres Strait Islander people. We know that people living in those remote areas have 3 times the avoidable death rate of urban residents. 29% of Australians and 26% of New Zealanders live in rural and remote areas. And yet, only 5% of our Australian specialists work in those rural and remote areas. So we have a real problem in our country of distribution of specialist care. So our specialist thyroid surgeons mostly reside in metropolitan areas, which means that many of our community living in rural and remote areas don't have the same access to that type of specialties. For 5 of our 9 surgical specialties, less than 5% of surgeons are based outside cities. A little bit about our history. Our College of Surgeons is has a similar history and length of time as your Indian Association of Surgeons. And in fact, our International Surgical Society is similarly about 100 years old. Prior to World War I, most of our fellows in Australia and New Zealand would obtain their fellowship in the UK. I noticed in Professor Shahar's address, he cited Professor Malcolm Wheeler from Wales, and I myself did my fellowship in endocrine surgery at the University of Wales College of Medicine under some great mentors. So many Australians have obtained their qualification in the UK, but after World War I, there are many surgical advances. This is often the case in times of war, and some of those skills were brought back to Australia. And in the 1920s, after an Australasian Medical Congress, which occurred in my hometown of Brisbane, there was a motion that the college establish a college to maintain surgical standards across Australia and New Zealand. And in the following years, a group of eminent surgeons commenced the Royal Australasian College of Surgeons on the 5th of February 1927. In fact, in 3 or 4 years' time, we'll be having our 100-year foundation. And it started with a very small little office in a corner building in Melbourne. And now, in about the pre-war era, however, a lot of those plans were put aside. And education didn't really return to the college until the 1950s. And prior to World War II, when the college first formed, membership was granted just by the very fact of being a surgeon. But in the 30s, it was determined that one would have to obtain fellowship by examination. And really, following World War II, a lot of our specialties started to emerge, such as neurosurgery in 1955, proctology. And now the College of Surgeons consists of 9 subspecialties. And in your area of specialty, endocrine surgery, it is one of a number of subspecialties of general surgery, breast being one, colorectal, upper GI, and HPB. Like a lot of your surgeons, many of us are breast and endocrine surgery. In my practice, I've had about 30% endocrine practice and about 70% breast practice. But nowadays, many of our surgeons are differentiating into endocrine only and breast only. The anaesthetists even were part of our college until 1992, when they separated and formed their own college. Other colleges which have separated from the College of Surgeons have been the ophthalmologists and the obstetricians and gynecologists. But now we have about 7,500 fellows across Australia and New Zealand and about 1,200 trainees. You know, we're a much smaller country than India, but we have one college, so we're all affiliated with the one college. If you want to train in breast surgery, we have a coordinated post-fellowship training program for about 2 years, and surgeons who've completed their FRACS and obtained their general fellowship will apply for 2 years of subspecialty training in pure breast surgery, where they will be trained across the full range of the specialty, including oncoplastics and reconstruction, etc. And there's a training and regulations and policy handbook. And if you want to look at that training, you can go to the website. I won't go through the detail of that. And similarly, for endocrine surgery, there is a post-fellowship training. Now, up until very recently, most surgeons wanting to do pure endocrine surgery looked for a fellowship at one of our institutions. And I know, for instance, Professor Gaurav Agarwal talked about his time at North Shore in Sydney. And many of us sought out fellowships, as I did. I spent time at Westmead in Sydney and then later on in Wales. But it's only in recent times that our endocrine surgery program has become coordinated across the two nations. And so now we have a very formal endocrine surgical training program where fellowships are allocated and the training is organised between institutions. Currently, that is a 1-year fellowship training with an option of 2. My current endocrine surgical fellow at the moment is planning to then go and do 2 years of breast fellowship with a total of 3 and be a breast and endocrine surgeon. But some fellows choose to do one or the other specialty. So you can see that from the time you obtain your medical degree to traversing your medical degree, doing your pre-vocational training and then your postgraduate training and then your professional development, it may be 14 to 19 years before you emerge as a specialist surgeon. Now, I understand I am the Breast Foundation lecturer, so I will mention to you my role as president of Breast Surgery International, and your director and head, Professor Agarwal, is the immediate past president. We're an integrated society of the International Society of Surgery, and the aims of our international society are to maintain the highest standards in breast surgery, to support and advance the science and art of surgery through clinical laboratory research, and to provide education and diagnosis in the management of breast cancer, not only in our individual countries, but particularly in developing countries. And we've formed a very close working relationship with surgeons right across the globe. And the next meeting of Breast Surgery International will be in Kuala Lumpur next year. The previous meeting was in Vienna in 2021. And in fact, Breast Surgery International was established in Vienna in 1999, and the first president was the renowned Umberto Veronesi. The International Surgical Society, of which we're a member organisation, was established some 100 years ago, and the first chair of that was a very well-known Theodore Cocker. So I would implore you all to consider coming to the International Surgical Society meeting, and many of you will have an endocrine interest, and that will probably be the last meeting in Kuala Lumpur where the International Endocrine Association will be with all the other integrated societies at the meeting in Kuala Lumpur. So please come along to that meeting next year. There are many reasons to be members of society. You heard from Professor Shah that the endocrine surgeons are the friendliest group of surgeons, and I think you would find the breast surgeons no less friendly. The reasons why you would want to join these societies, obviously for the educational benefit, but the collegiality. And for those of you wanting an academic pathway, there is nothing better than to build up your international connections and have those introductions and develop those friendships. So certainly would encourage you to step outside of your country and join with others in these international societies. I've listed here the 10 RACS competencies that we speak about, and you'll see from these 10 competencies that medical expertise makes up only a couple, medical expertise and technical expertise. Most of the competencies that we want to assess in a surgeon relate to other areas that are very important to being a competent surgeon, such as collaboration and teamwork, judgment, decision-making, professionalism and ethics, scholarship and teaching, to name just a few. So when we assess our surgeons, we do so, they're assessed throughout each term and at the end of each term for their competency base. And they have entry and exit exams. But all of these competencies are assessed throughout the training. I like to talk to my young colleagues about professionalism. Professionalism is not a 9-to-5 job. it's not a 5-day-a-week job. You are entering into an esteemed profession, which is really a 24-hour-a-day, 7-day-a-week job. That's not to say that the surgeons of today want to work some of the ridiculous hours the surgeons of yesterday worked, but being your patient advocate and having the patient in the center of everything that you do is something that's pervasive and something that exists at any time. You as a surgeon are on call for your patients 24 hours a day, 7 days a week, regardless of what else is going on in your life. Because as a professional, you are quite different from the paid employee. You have specialized knowledge, competency, honesty, integrity, accountability, and self-regulation. And when I talk about image, I guess what I'm talking about is our social contract with the community. And we have an obligation to the community that goes well beyond what our paycheck tells us we do, or what our job description tells us we do. In Australia, surgeons are the highest paid professionals. You can see that list. We're higher paid than our anaesthetic colleagues. The financial deal you see comes in number 3. We are on large incomes, and with that comes a huge responsibility. Yes, you should live a very comfortable life as a professional, but if you're in private practice and charging well beyond what's reasonable, then that's very unethical. So when I talk to my young colleagues, I say to them that you as a professional deserve to live a comfortable, well-paid existence, but never underestimate your social contract and your ethical responsibility. So why did I choose breast and endocrine surgery? I love the combination of breast and endocrine surgery. And in my private practice, I have the ability to have long-term relationships with my patients. So I've always had a mix of private and public practice. I find breast cancer, the breast side of my practice, to be a great intellectual challenge. In fact, most of my research is around breast surgery. But there's nothing quite like the technical challenge of head and neck surgery and thyroid and endocrine surgery and adrenal surgery. It's clean surgery. It's fascinating anatomy. There's intricate detail. And, when I set out in surgical training, I was absolutely going down the colorectal pathway until a mentor sat me down and told me I should do breast and endocrine surgery. And I'm so thankful that they convinced me to do breast and endocrine surgery. It's a great speciality. But one of the good things about the patients we treat is they tend to have lower morbidity. They tend to have shorter hospital stays, fewer out-of-hours emergencies, and there's an abundance of research opportunities. In fact, in my very early days in the 90s, it was by surgical mentors. Some of those photographs you can see there are people who have been presidents of our college, have been esteemed researchers and consultants. And they're people that in my very junior days gave me the opportunity to publish my first publications as first author, publish small publications, but giving me my start in research. So what I'd say is look for your mentor, develop your area of interests, think about how you want to theme your research, and look for collaborations and expand your networks. I think Professor Shah showed you a great pyramid of how you reach that pinnacle of academic achievement. These days, I'm less a clinician. I'm far more a researcher and administrator, and I do very little clinical work. But it has freed up my time to focus on the research. We spent the better part of 10 years implanting mini pigs with biodegradable 3D printed scaffolds. And 12 months ago, we performed the first human implantation of 3D printed polycaprolactone scaffolds with fat lipofilling. And so far now, as part of the first phase 1 study, we've performed about 13 of these cases, all going well. And I believe that these biofabricated scaffolds are going to be a real game changer in reconstruction going forward, and a much better alternative to silicone implantation. But it's the basic science that leads you to the translational research. And some of the research we do is around innovation. And we heard a lot of our speakers today talk about innovation. What we've done in our institution is use proven technologies such as seed technology for localizing lesions, intraoperative radiation, one-step nucleic acid assay, and evaluation of sentinel lymph nodes. All of these things together can shorten the pathway of care. We know in breast cancer, the survival is so good now that we've really got to focus on what things can improve quality of life. And we know that if we shorten the pathway of care, we shorten the time to patients getting to the adjuvant therapy. And the public health benefits are enormous. I look back at the times that I've spent in research, and there's some of the research we do has a very, very long tail. We did one of the earliest trials, randomized clinical trial, when sentinel node biopsy was just being explored. 20 years ago, our research group formed the SNAC group that randomized sentinel node biopsy in 32 institutions across Australia and New Zealand. And only this year, we've published our 10-year results. So when you're involved with research such as clinical trials, it can be a long time before you see the benefits, but the very fruits of that activity. So when I talk about academic work, public work, private work, why do we do that? Well, we do it because surgery offers such a rich fabric of opportunity, and such a it's the profession that keeps giving. But I'd also say that as a surgeon, as you climb that leadership ladder, you're working in a high pressure area, long working hours, and all that leads to prestige and promotions, and career achievements are highly valued. I'm from a typical Asian family. I was encouraged to seek a profession of good standing, and it is a very honourable profession. And high pressure jobs are sometimes paired with big paychecks, but individuals can find themselves launched into a new socioeconomic class. And what I'd say is free up that time, start small, build your networks, decide what's important to you, and look beyond your job title, because you're going to need to find balance and focus. People often say, how do I do all the things that I do? And it really comes down to time management. I don't know if any of you are familiar with this Eisenhower decision matrix, but I find this very useful. In fact, I apply this to my email inbox, of which I receive about 150 a day. I'm sure many of you do. There are some things that are urgent and important, and you just need to do them straight away. And some things are important, but not urgent. Decide when to do them. Some things are urgent and not important, delegate them. And some things are just not important, not urgent, and you should dump those things. And make time for your family. This is my wife and my 4 all adult children. I've now got grandchildren, but happiness in your professional life will give you a happy home life. Thank you very much for your time, and thanks for listening to my musings. And I'm going to stop sharing my screen.
Yes, sorry. Thank you very much, Professor Ru, with a very enjoyable, comprehensive talk on leadership role and training in breast surgery. I think all of us enjoyed much, and it was a very welcome introduction to new young surgeons who are training in breast surgery. And as is customary, usually there are no questions taken after a oration. And I am happy to inform you that you must have witnessed that I have received memento on your behalf. And I'm sure we will meet sometimes and I would be able to hand over it to you. Thank you so much. And on behalf of Department of Endocrine Surgery, I express my heartfelt gratitude. And we are really indebted that you have taken time out from your busy schedule for this oration. Thank you very much. Thanks again.
Thank you, sir. I now request Dr. Sabaratnam to prepare.
Good evening, everyone. It's an honor to have been asked to offer the vote of thanks on this occasion of Foundation Day. We have already learned a great deal from our speakers. I thank our honorable and respected director of this institute, Professor R.K. Dhiman sir, for his valuable time and support for the department and to the institute. I immensely thank Professor Vijay Oja, the chief guest, for his valuable time and his great address. We thank our Dean, Professor Shalin sir, for his time. And I thank our respected HOD, Professor Gaurav Agarwal sir, who is my teacher as well, for his constant encouragement and never-ending support. I thank the other faculty of Department of Endocrine Surgery, Professor Anjali Mishra ma'am and Professor Gyan sir, Dr. Vishwat Chandar, Dr. Sushoban Pradhan, and Dr. Fareen Khan. We thank renowned faculty in head and neck surgery, the Professor Ashok Saha, who's my mentor in thyroid cancer as well, for the wonderful Foundation Day oration. I thank our breast surgery orator, Professor Owen Wong, for his interesting oration. I thank Professor Jin Wook Yi and Mrs. Haimi from Incheon, Korea, for coming here and helping us with the workshop. I thank all the members of Department of Endocrine Surgery and all the faculty members of other departments, senior resident colleagues of Department of Endocrine Surgery, all 12 of them, and all nursing staff, lab staff, and members of SGPGI family for their contributions for this meeting and patient care. I thank all alumni faculty, other faculty members of this conference, endocrine surgeons, other members of medical fraternity who have joined physically and remotely for this meeting. It's our privilege to host all of you for this PGES and Foundation Day. I thank the press, the sponsors, the telemedicine personnel, Mr. Ripuji, Dabirji, Mr. Amirji for transport, Mr. Vinayji, SRCP India, Mr. Inder Mohanji. Smallest act of kindness is worth more than the greatest intention. Thank you, everyone. If I miss somebody, thank you.
Thank you, sir. May we now request everyone to kindly stand up for the national anthem.
Punjab, Sindh, Gujarat,
On behalf of the entire Department of Endocrine Surgery, we would like to thank you all for sharing your valuable time with us and making this occasion memorable. We now request all the guests to join us for high tea.
Take care, Professor O. Enjoyed your talk very much. Excellent. Take care, Gaurav. Thank you.
Thank you. Thank you, Dr.
Okay.
Shah, Dr. Ung.
Thank you, Gaurav. And I also enjoyed your talk, Professor Shah, very much so.
Thank you for being there. Enjoyed.
Bye-bye.
Bye. Take care, Gaurav. Bye.
Thanks.